Hello everyone, I am nithish, final year from Chetna Dental College and Research Institute. Today I am going to teach you a topic on white spot lesion. What are the topics covered in this lecture? First is introduction, etiology, predisposing factors, diagnosis and differential diagnosis, prevention and treatment, and conclusion. First, what is white spot lesion? Coming to the introduction, non-cavitated caries lesion or white spot lesion or incipient caries lesions is the first evidence of caries activity in the enamel. It appears as a chalky white opaque areas on enamel when air dried, but it seems to disappear when the tooth is rehydrated or made wet. This opaque appearance is due to the loss of minerals, that is demineralization from the subsurface enamel, which alters the enamel's refractive index. White spot lesions are non-cavitated lesion, meaning the outer enamel surface is still intact. This makes them reversible with proper intervention. They are a result of the imbalance between the mineralization and demineralization, which if not intervened may further lead to the irreversible damage like dental caries. In early lesions, the mineral content in the affected area is reduced, which in turn affects the transient features of the enamel, and the color of these appears more opaque than white. Hence, they are termed as white spot lesion. What are the etiology of white spot lesion? There are mainly four etiologies. First is plaque and bacteria, then next is demineralization, subsurface lesion, and refractive index changes. Coming to the histopathology of the white spot lesion, histopathology of white spot lesion has been divided into four zones from the outermost to the innermost zones. The first is the outermost zone, is surface zone. It is a relatively intact outer layer, approximately 20 to 50 micrometers in thickness. It is more mineralized than the body of the lesion. Next is the body of the lesion, the largest and most demineralized part of the lesion, making up the bulk of the lesion. The pore volume here can be as high as 25%. The next zone is the dog zone. A small porous layer beneath the body of the lesion is the dog zone. This area is considered as a sign of remineralization process taking place, as some pores are filled with remineralized material. The abundant remineralized material is seen in the dog zones. Next is the innermost zone, which is translucent zone. It is the deepest part of the lesion, which is often difficult to see. It is slightly more porous than the sound enamel. Coming to the diagnosis of the white spot lesion, there is various methods of diagnosis. First is visual inspection. The primary and most accurate method of diagnosis is the visual inspection. The lesions are most visible on a clean, dry tooth surface, but if the tooth is made wet, the whitish layer or the opaque layer disappears. Next is the tactile examination. A sharp explorer should not be used to probe the lesion because it is an outermost layer which is soft and it is in whitish layer and opaque layer. So the surface is intact and probing can cause irreversible cavitation. A gentle blunt probe can be used to assess the surface lesions. Next is transillumination. A fiber optic light can be used to shine through the tooth. The white spot lesion will appear as a dark shadow due to the light scattering. These white spot lesion comes under the classification of ICDAS, which is the International Caries Detection and Assessment System. In the ICDAS code 1 and code 2 comes under the white spot lesion. First, the ICDAS code 1. It is the first visual change visible only after air drying. Next is the ICDAS code 2. Distinct visual changes is seen visible when wet. What are the risk factors for the white spot lesion? The most commonest risk factor is poor oral hygiene due to the accumulation of dental plaque and bacteria. Next is a diet which includes mostly the sugary foods. Next is the reduced saliva, and ortho treatment induced white spot lesions are more common in orthodontic treatments. Next, what are the common locations of white spot lesion? The common locations of the white spot lesion in the teeth are buccal and lingual surface of the tooth, and the smooth surface of the tooth, and around brackets of the orthodontic treatment and interproximal areas. And it is also most commonly seen in the gingival margins. What are the management strategies for the white spot lesion? The first and foremost management strategies of the white spot lesion is arresting the caries. So for arresting the lesion, the primary goal of modern operative dentistry is to arrest and reverse the demineralization process, rather than to immediately restore the tooth. So this is a key principle in both Studevant's and Grossman's philosophies, where arresting the lesion is most prominent and foremost method of control. Next is the minimal intervention dentistry. These approaches focus on area direction, risk assessment, and non-operative treatments to preserve as much tooth structure as possible. There are two types of management. One is non-operating management and the other one is operating management. Coming to non-operating management, remineralization and fluoride therapy are non-operating management. In remineralization, the most conservative and effective approach is remineralization. It involves applying agents to help minerals to re-enter the enamel and induce the remineralization process of the enamel. Next is fluoride therapy. The professional application of high concentration fluoride varnishes, gels or rinses are used, and daily use of fluoride toothpaste is also crucial in maintaining the white spot lesions. Next is improved oral hygiene. Patient education motivation are paramount importance in preventing and controlling the white spot lesion. This includes proper brushing technique, flossing, and the use of interdental brushes for orthodontic patients. Coming to dietary counseling, reducing the frequency and quantity of sugary snacks and drinks, and before consumable of sugary foods before bed is also restricted. Next is the operating management. Operating management includes microabrasion and resin infiltration. Coming to the microabrasion, a technique for superficial lesion, it involves using an abrasive dry slurry, pumice or hydrochloric acid to remove very thin layer of affected enamel, masking the white spot. Next is the resin infiltration, a minimally invasive technique for deeper lesion that have been cavitated. So resin infiltration is used for the non-cavitated lesion. A low viscosity resin is infiltrated into the porous enamel lesion. The resin has a refractive index similar to sound enamel, which masks the white spot and also creates a diffusion barrier to stop further demineralization. Next is the last sort of treatment of white spot lesion is a restorative treatment, only indicated for lesions that have progressed to the cavitation. That is called frank caries. The lesion has been transferred from the surface to the deeper caries. This cavitated area is prepared and restored with a filling material like composite resin. This is considered the last sort of treatment for the white spot lesion. Conclusion. Coming to the conclusion, white spot lesion is a major clinical problem. Once the lesion is established, it is hard to achieve complete remediation. So early prevention and control of the white spot lesion is very paramount importance than leading into the cavitation. The optimal oral hygiene is necessary to avoid the white spot lesions. Regular dental visits and use of oral prophylactic aids are not negotiable. Fluoride is a major ingredient that is karyostatic and is capable of arresting the lesion. Hence, judicious use of fluoridated toothpaste and mouthwashes are advocated. These are the references we have gone through to make this lecture most helpful and wonderful. Thank you for your cooperation. Thank you.